sejahtera dan selamat pagi kepada semua. Terima kasih. Thank you for attending today's webinar. And thank you also to our speaker, our guest speaker, Professor Zarina Abdul Latiff, who has agreed to give this talk this morning. For your information, Professor Zarina is the external examiner of our Master of Pathology Medical Genetics program, which concluded yesterday. And we have invited her to give this public lecture, and she has agreed, and we are very thankful to her. So I would just give a brief introduction of Professor Zarina. I'm sure most of you know her. It's a long list of, but I would just mention the relevant achievements. So Professor Zarina is a senior consultant pediatrician and clinical geneticist at the Fakulti of Medicine, UM Cheras, Kuala Lumpur. She was previously the Deputy Dean of Postgraduate Studies at the Faculty of Medicine, UKM. And before that, she was the head of the Department of Pediatrics at the same faculty. And she was also the Clinical Molecular Biology Institute, or UMBI. And currently, the head of the Thalassemia Center at Hospital Chancellor Tuanku Mukris, UKM, Cheras, and also a committee member of the Clinical Management and Support of Rare Diseases at the Ministry of Health, Malaysia. He is a member of the Specialty Education Subcommittee for the Malaysian Medical Council, or MMC. And currently, she is the EXCO member for the Malaysian Genetic Society, or PGM, and also the EXCO member of the Malaysian node of the Human Variant Project, or MyHVP, and the executive member for the Global Globin Network. Is the Education Committee of the HUGO, or the Human International Genome Organization, HUGO, and she is also the head of the subcommittee for education of the Education Committee. So she has a long list of publications, which I will not mention here, and also a long list of postgraduate students and grants. But suffice to say that she has, and I think at PPUKM. And because of that, she and challenges on counseling is most appropriate. She is the most appropriate person to give this talk. So, ladies and gentlemen, please welcome Professor Zarina. The floor is yours.
Thank you, Prof. Zulfalil, for the kind introduction. Just like to ask whether you can all hear me. Can you hear me, Prof. Falil? Okay, thank you. So I'd like to also thank, Dr. Zarina Sulong and her team at Pusat Genome in USM for this kind invitation, right? I have a long working relationship with USM, and it's always a pleasure to be back, although virtually, with everybody in USM, right? So I think I probably can start my talk for today, and allow me to share my slides. Right. So Can you see my slides? Yes?
Yes, Prof. We can see your
Okay.
slide.
All right, thank you. So, so today my talk will be about the professional needs and challenges of genetic counseling. Okay, so for the next hold on, that disappear. Okay, so for the next 45 minutes or so, I would think, I will be talking about this. My content of my talk will be about the scope of genetic counseling, the ethical framework and social-cultural issues related to genetic counseling. And this is a big topic, but I'm just going to highlight some of the key points. And this is especially important because Malaysia is a multi-ethnic country. So we need to be mindful about what are the social-cultural issues that we may come across in our practice. And I'll be talking about briefly about genetic testing, especially with the evolution of high throughput technologies, and I'll touch a little bit upon direct to consumer testing. And how we practice genetic counseling is different nowadays as to what was traditionally practiced. I think we are still evolving here in Malaysia, but now overseas we talk about mainstreaming or genetic counseling. And I'd just like to highlight a little bit about the situation of rare diseases in Malaysia, because as we know, the majority of rare disease has got a genetic etiology to it, and what has been done by the Ministry of Health in terms of its national framework. And to wrap it up, I will highlight about 6 cases that I have come across and managed, okay, in our clinical practice in previously HCTM, and now we have set up our practice in the Children's Hospital, HPKK, right? And a single slide to summarize all my points. Okay, so when we talk about genetic counseling, it's basically a client-centered process, and it involves a communication process with the aim of helping individuals understand and adapt to not only medical, right? Not only the physical aspects of the disease, but we also want them to, we want to assist them in adapting to psychosocial, familial, helping them understand the reproductive implications and providing reproductive options of the genetic contributions of that particular disease, right, to the client, to the patient, and to the family. Okay, so in other words, genetic counseling is a process which helps the client or the patient or the family member here to incorporate genetic information into their lives, to help them adjust to it, rationalize, and to think through how they want to act upon this information that has been given to them. And of course, because some of the genetic diseases, some may be spontaneous, but some will have a familial pattern or inheritance pattern to it. So when that happens, then cascade testing amongst the other family members becomes an option. So then we would like to help the client rehearse how to explain it to their relatives, so as to empower them and to facilitate the process of cascade testing within the family members themselves. So the responsibility is vast, okay? So we're not only talking about the patient or the client, we also talk about the family members. And because a lot of these diseases have a multidisciplinary approach, so there are specialists from various subspecialties that could be involved in managing the patient. So we have to have a good collaborative understanding and relationship with our clinical colleagues, and certainly, right, we'd like to make sure that the society are aware and have a better knowledge and understanding of the condition itself, right? And I think that is very important, so that everybody is aware and tolerant and understand the impact of that disease towards the patient. So when we talk about genetic counseling, there are two big arms that we want to look into: the ethical perspective and the professional perspective. And a lot of the time, both of these merge together. Okay, so from the generic aspect, when we talk about ethics, right, it's about understanding and examining the moral of life, and it's related to issues about clinical encounters between the health personnel and the patient. So we all have heard about this, the four pillars of ethics when it comes to medical practice, which is autonomy, right? So we provide informed choices to our patients, right? So previously, me in my training days, I will be prescribing, writing out a prescription and writing out what needs to be taken at the pharmacy. But when we talk about genetic counseling, is the information that we give. Now that is what's important, right? So when the information becomes knowledge to the patient, then we have empowered the patient or the client, then we have done, inshallah, something positive, right? So only then, when we have given informed choices, that we'd like to allow the client or the patient to have autonomy in their decisions, right? And of course, another ethical aspect, a pillar, would be beneficence, right? To do good to the patients, non-maleficence, to do no harm, and of course we talk about justice. So we not only talk about genetic justice here, but we talk about equitable access. So we'd like all our patients who have genetic diseases, rare diseases, to be able to come forth and get treatment at centers that offer genetic services. Okay, so the next big perspective that we'd like to look into is the professional arm, and it is closely related to the ethical perspectives here. So when we talk about professional needs, it embodies the relationship between medicine and society. And this is where it's important that there is patient-physician trust. Of course, there must be professional boundaries, but if there is no trust, then how can the patient then want to come forward and listen to what you have to offer, right? Although the decision is theirs, there must be a form of trust, okay, between the physician, or here the genetic counselor, with the patient or the client. And of course, it is a moral endeavor. So it requires a high level of competence, integrity, and high ethical standards, right? So here in Malaysia, we do not yet have the accredited body, right? A professional body that accreditates genetic counselors. Not yet, right? But we can still use what's available in the United Kingdom, Australia, and so on, right? So this is very important when we talk about genetic counseling. There must be adherence to a specific code of practice. So, when we talk about genetic counseling, we apply the knowledge in both a culturally and ethically sensitive manner. And this must be applied at multi-levels, okay? So, at the intrapersonal level, that means you need to understand what the client, or even you yourself as the counselor or the physician, may have your own knowledge, attitude, and beliefs. But you need to understand what is it that's happening with the client or the patient. And then, of course, interpersonal, right? So these are the social norms, the social cultural aspect. What does the community feel towards certain aspects, okay? And then we talk about institutional, where they must have access to the resources and services. So this is talking about the equitable access that I mentioned earlier on. And of course, we talk about policies, right? There's always that fear of genetic discrimination, and that you need to always adhere to confidentiality, right? So I don't think we have, as of yet, just with the code of practice in genetic counseling, but in the United States, right, they have the GINA, right? So Genetic Information Non-Discrimination Act, which was put forth in 2008. So this is to protect those individuals that have genetic associated diseases against discrimination when it comes to employment and when it comes to health insurance, right? So sometimes when we don't have a particular act here or a specific legislative framework, it is still important for us to refer to what is available elsewhere and to adapt accordingly. Okay. So this is the 4Rs framework that was proposed by Phillips and et al. In 2012. So this is relevant for patients in which there is multidisciplinary healthcare. But certainly, as I mentioned, because genetic patients do require multidisciplinary approach, so this will be absolutely relevant in our practice too, right? So we need to understand what are the roles of each of the team member so that we can work towards providing what's best for the patient. And of course, there are codes of practice, rules and regulations that we need to adhere to, right? We need to do this and we need to be respectful of the boundaries that each of us hold, okay? And because we need to work for the patient's best interest, we need to have a good working relationship, right? With the patient and certainly amongst the colleagues, right? And of course, we need to understand what our responsibilities are, right? We can't assume that, well, that specialty should be doing this. That's not my responsibility. But sometimes we need to work together, okay? So we need to be mindful of each other's responsibilities. So when we talk about a consultative ethical framework in terms of clinical genetics, it's about recognizing what ought to be done, okay, in the professional context. So there always must be professional boundaries, okay? So when we talk about clinical genetics, our responsibility is not only to the patient or the client, but because the disease is potentially inherited, then the consequences could be to other family members. So it's always good when you are faced with in doing a consultation, you need to list who. WHO here is who, not World Health Organization. You need to list who are the important people that may be having an impact from the result of this disease. Okay, it could be an unborn child, right? Maybe the mother of the patient that you are managing is now pregnant. So, you know, you have to talk about what can be done. Can we do diagnosis? What is the risk assessment and so on and so forth. And similarly for the siblings. So the responsibility of somebody who is practicing clinical genetics and also doing genetic counselling, meaning the genetic counsellors, is a lot bigger. Okay, so you need to also think about what are the potential solutions. Are there medications? Is it curative? Right? If it is, then who do you refer to? Do you need to refer for, if it's an inborn error of metabolism, are there enzyme replacement therapy options? So if there is, then you need to know who to refer to, okay? Because such treatment does take a lot of, there is a lot of financial implication, right? So I think you must do justice for your patients, okay? So we need to refer accordingly. And of course, now we talk about the days of gene therapy, right? So it's not available yet in Malaysia, but I think genetics and certainly medicine as a whole is something that you need to always be keeping in touch with what's new and what's current, because you can't be offering a solution that was available 10, 20 years ago. It's no longer relevant, right? Then you're not being fair to your patients, okay? Right. So so as I mentioned, some of these treatment could be a little bit more expensive. So there need to be guidelines. Okay. So when I talk about formulate coherent argument, perhaps guidelines would be a better word here, or so that we can work together, right, as a team towards a decision for the patient's best interest. Now, when we talk about ethical perspective again, because when we are dealing with the client, it is a deep engagement. It is a process that involves the head because of the sheer amount of scientific information that is available, and the heart, okay, because there will certainly be a lot of emotions involved. So this is a very complex process. So facts of the matter is the cognitive aspect. Okay, we need to make sure that the patient understand, because you know there's a lot of medical jargon, right? I mean, even amongst ourselves, and certainly now with mainstreaming, right, and the need to engage general practitioners and non-genetic professionals, right, to impart knowledge. Well, that can be certainly a handful. So that's even more challenging when we want to share it with the general public. Okay, so there's facts of the matter that you need to think about how you're going to do this in the best way. And of course, right, there's awareness. There needs to be awareness on your part about the likely response of the client. So there could be some emotional contexts that are involved. Okay, so there could be differences in opinion between you and your client or the patient, differences in opinion between the woman, the mother maybe who is pregnant, maybe with the husband, right? Differences in opinion between the patient, if it was an adult patient, with the other family members. So you need to be mindful, right? And you need to recognize that there could potentially be a lot of tension, right? So and this may get in the way sometimes of the patient getting the necessary information or doing the necessary testing that will be beneficial. Okay, so we need to be aware about this. Okay, and because there's emotions that are involved, sometimes it becomes a little bit more challenging, so we must remain objective as far as possible. Okay, and to make sure that there are rational elements that are there, is well grounded. In other words, the decisions that is ultimately made must be well grounded. Yeah, because sometimes we are only human. We can easily, you know, be emotional and let our feelings get the best of things when we are angry. Okay, so that's why when we do a pre-test genetic counseling, it is best to give some time, okay, for the patient or the client to digest all that facts of the matter, right? And then only come back and do the test at another time, okay? So at the end of the day, it's striking a balance in ethical consideration. So I've mentioned about the one of the 4 pillars of ethics, which is autonomy. So once you have provided sound information, up-to-date information, unbiased information, those are what you call informed choices. So then the patient, client decides for themselves what is best. Okay, so that's autonomy, and I've already mentioned about the need to maintain privacy and confidentiality. Always put the patient's personal best interest at heart. And the responsibility here is not only for the client or the patient in front of you, is also for the future siblings. Okay, and when we talk about genetic counseling, right, we have to talk about providing reproductive options and let them make the decision. And this is what we talk about, reproductive liberty within certain frameworks, social, cultural, legislative framework, right? Remember, what is practiced elsewhere in the West may not necessarily be accepted or legal in certain countries, maybe in the East. So we need to know what is right, okay? And I've already mentioned about genetic justice, right? I talked about non-discrimination, and this is very important. So I think for us to make sure that our patients are well treated, that they are not they allowed employment, okay? And I think how to do this also is to increase the knowledge and awareness of the general public, okay? And because some of the tests and the medications may be expensive, I think here I'm trying to touch upon is you need to be able to support, all right? I mean, you know, based on the universal health coverage that's put forth by WHO, United Nations and all that, rare diseases, patients with rare diseases should not be left behind, okay? So although it is expensive, I think we must work together to see how we can best provide solutions. And of course, if there is a better solution, we use the one that is cheaper, but sometimes it's not always available, okay? So so there's matters about social cultural aspects that we need to be mindful when we are doing counseling. Yeah. So the family dynamics, I think in the in the Eastern, right, we're probably known to be a little bit more conservative, reserved, right? So, but not necessarily so. There shouldn't be stereotyping, but we need to be aware about that, okay? So we need to identify potential barriers, okay? Whether there is helpful intervention, and sometimes there could be geographical distances, right? Because a lot of our services are centered in the larger cities, right? Previously, it was only in like Kuala Klang Valley or in Kubang Krian, but now it's been extended to Penang, and there are also clinics that's been conducted every now and then in the East Malaysia, okay? So we need to overcome these barriers, okay, so that there is equitable access for our patients, right? And of course, I've mentioned about family dynamics. There could be estrangement, okay, whether there's any emotional concerns, and gender roles, okay? So this may be especially important if, like, let's say if it was an X-linked recessive condition in which the mother has been confirmed to be a obligate carrier. So the woman, would like to fulfill the role once married, perhaps, to have children. Yeah. So we can't assume this, but that could be what the person wants. Okay. So with a condition in which the woman is an obligate carrier for an X-linked recessive, then she might have what is called genetic guilt. Okay. So we need to be aware about these barriers that could be there. Okay. And sometimes there's just so much information that you want to share. I remember when I was started out first as during my early counseling days, there's just so much you want to share. You want to share A to Z if you could, right? But you have to remember the patient will only remember a certain amount of information, because remember, the amount of information can be quite complex. Okay. So you need to set your goals, okay, when you have a counseling session. And even then, when you have streamlined your information, it would be useful if there was some sort of written information that could be referred to as a backup. So whether it is a letter, whether it is an informational pamphlet, okay, so something that the client or patient can take back, okay, or provide a link, okay, that is that may be useful, okay. So right. So this is a paper written by Adrina Zong et al. In quite recent in 2018. So this was talking about the barriers, okay, and some concerns that are present in the lower middle income countries. So it's been divided into ethical issues, social issues, and cultural issues. So you see, again, there are multi-level perspectives, right? From individual to community and the development of public policy. So for example, when it comes to ethical issues, right, this review here where they looked at several clinical genetics set up in various countries, okay, they found that the genetic counseling tends to be directive. Remember I mentioned about active non-directiveness, but apparently it's being very directive, right? So as a medical personnel, I think a lot of the times we are indeed very directive, but when we talk about genetic counseling, we're going to have to look at it in a different manner, okay? And the other thing related to ethical issues are about maybe the support given to treat the patient, the physical condition is available, maybe, but the psychosocial consequences, they found that this needs to be handled much better in the lower middle income countries. So what about social issues? So the social issues here, number 3, you can see here, right? Here at the institutional level, okay, probably at the national level also in Malaysia, right? It's seen that medical genetic training could be inadequate, right? So here we're talking not only about inadequate in terms of numbers, perhaps, or now if you're talking about mainstreaming and direct to consumer testing, so the non-genetic professionals also need to be a little bit genetic savvy, so to say. So the number of clinical geneticists, right, and the number of genetic counselors are very, very limited in Malaysia, okay? And genetic services could be difficult to access because it tends to be centralized. So this doesn't sit well if we're talking about universal health coverage and we're talking about equitable access. So there's room for improvement about this. And of course, I've mentioned about social determinants, and sometimes beliefs may get in the way of whether somebody wants to come forth for genetic testing, whether somebody wants to do prenatal diagnosis, for example. Okay. Then social stigma, so that's still present, so that's related to probably genetic discrimination. Then you have to be mindful about family values, religious principles, especially us being a multi-ethnic country, right? What do the Muslims perceive this to be, right? Especially if it's talking about termination of pregnancy, from the Muslim perspective, the Catholic perspective, Buddhism, and so on. Okay, so you need to be aware. Okay, and again, the other local cultural beliefs and practices. Okay. So now moving on to the aspect about genetic testing very briefly, because now we are in the genomic era where we have a lot of high throughput technologies. So the more data that is being generated, and these data are very complex, the harder it is and the more challenging it becomes to make sense of it, right? So how do we actually translate it? How will it become important or useful for the client and the patient, right? So the patient's needs, right? The interpretation and recommendation needs to be guided by evidence, right? So this is what we call evidence-based medicine, right? So some of these genetic results or the reports may be provisional, right, rather than definitive. I think every now and then when we see a patient and they have a particular genetic variant, for example, right, especially if we're talking about that's involved in polygenic disease, okay, they want to know, well, am I going to develop this disease or not? And that becomes harder, right, on our part, because maybe we've only detected that one variant in one of the gene, but there are many genes involved in that complex disease. Okay, so it becomes very challenging when we want to counsel the client. Okay, so as a result, because there's just so much data that is being generated, right, the consent for genomic investigations is a lot broader. Okay, and there's always this issue about diagnostics. Are you doing the test for diagnostics, or is this on a research platform? But even if it's on a research platform, consent must still be taken and there must still be pre-test genetic counseling. And sometimes maybe you are looking at a particular set of genes and maybe the patient doesn't want to know about any of the other genes that could possibly be sequenced, especially when you're talking about whole exome sequencing. Well, then the patient does have the right to not know that. They can choose to opt out. Okay. So of course, with all that complex data comes this issue of variants of uncertain significance, right? So previously, right, in 2015 anyway, this is classified when you get a variant, right? It could be classified as being non-pathogenic, unlikely to be pathogenic, of uncertain pathogenicity, likely pathogenic, definitely pathogenic. Okay, so how does one then or understand a CNV result which indicates modest susceptibility to autistic trait or learning disability? Because remember, a lot of these complex diseases like autism spectrum disorder, it is there are multiple genes involved. So if you have detected one, can you say with absolute certainty that the future offspring will develop autism? Because I think a lot of time the parent would want to have reassurance. They want to know definitely. Okay, so it becomes very challenging in the clinical practice. Okay, and what about incidental findings? Okay, the secondary findings, like I mentioned to you, we probably are looking at certain genes. All right, so even your whole exome can be a bit more targeted nowadays. Okay, but you can also, if you do whole genome, then you're opening a Pandora's box. Okay, so that's why the consent taking must be done well. Okay, so that the client understands the full impact of the genetic test. Okay, so according to the ECMG, American College of Medical Genetics, there are 73. They keep on increasing the number of genes. Before 53, 73, and I think in future it will keep on increasing. These are your actionable genes. So these are the ones that they will report. But whether the client or the patient chooses to know, well, that is written and signed during the consent taking, right? Some patients or parents don't want to know about the other things, okay? Because it is actually a Pandora's box. You're really giving a real lot of information, okay? So the issues when it comes to whole genome sequencing is the uncertainty of interpretation, especially if you're talking about somebody who has no positive family history, right? A healthy volunteer, for example. It could be incomplete sequencing coverage. And then when you find a variant, you say likely to be pathogenic, okay? You're not so sure. Then do you trigger further investigations? And how far do you go? So once you trigger and you do say like if it was a cancer syndrome, you need to initiate because it's a potentially fatal condition, right? Then to what extent? So you need to remember about the burden, financial implications, okay? Not only to the patient, but the health system at large, okay? So if you ask me, and also based on this paper, well, that was in 2014, but things are being fine-tuned as we talk, okay? I have not used whole genome sequencing in my clinical practice, okay? But I have used whole exome sequencing. So maybe you have to really think about how useful is it to use one particular test. The more sophisticated test does not necessarily mean the better it is, okay? So let's talk about direct to consumer genetic testing. So this is available, or what we call over-the-counter testing. So by 2025, okay, that's about 3 years' time, all right, there would have been about 60 billion patients globally who would have had their genome sequenced in the healthcare setting. So that's a tremendous amount, okay? And the problem with direct-to-consumer genetic testing is it tends to bypass the traditional healthcare system because it is provided online. So the client can just contact the providers, okay, and they may not necessarily be a clinical health personnel involved. We hope there is, okay, but sometimes they may not be, okay. And the platform that is being used, okay, we need to be aware. What is it? Is it a SNP chip genotyping or full genome sequencing? Okay, we need to know. And sometimes when the client chooses, if they're not been well informed, then and they don't know what they're in for, perhaps, okay? So there's also could be concerns about validity and clinical utility, as I've already highlighted, especially for complex traits, right? I think I know that in Malaysia, the wellness testing, when we talk about obesity, whether that person will be good in sports, etc. Yeah, that's being done at the moment, yeah, off the counter, okay? But what about for the other complex traits like autism, hypertension, diabetes? So we need to know how useful will this information be, okay? So consent is important and confidentiality. There's always that worry because not trying to be accusing the providers, but there's always that worry sometimes whether the confidentiality is maintained by the provider, okay, or whether the data is being used for research on the side, okay. And as I've mentioned, if you find a particular variant that could be likely pathogenic, that could trigger, okay, testing, surveillance, and they could be a potential burden. I put that in inverted. I mean, it's important for the patient. We want to be helpful and do what's best, okay? But at the same time, we need to understand that when we do this, are we ready for what's coming after that, okay? So, the American College of Medical Genetics and the European Society of Human Genetics mentioned, right? They have already advised that companies or providers that give this direct-to-consumer genetic testing should provide independent pre- and post-test counseling by trained professional, okay? So this would be in the ideal setup, okay? So I know sometimes when the providers give this test, they train some of the personnel, okay, to handle the results, okay. But to what extent are these professionals trained? I think that's the worry, okay? Maybe if the client is lucky, it is a certified genetic counselor. But if less, not so lucky, maybe there was no pre-test counseling, okay? So all this legislative framework needs to be in place, okay? So at the end of the day, the client is looking for a predictive or a definitive answer. And if you're talking about a disease that is polygenic, okay, that has multiple genes involved, okay, then there's a move now. Okay, where we're talking about polygenic risk scores. Okay, so perhaps this is a whole another big field. Perhaps those who are interested can go back and read about this. So this has been published for certain diseases, but it is still very challenging. Okay, and when we talk about this type of DTG, direct to consumer testing, they are genotyped at specific genes and at specific points. Okay, so it may be useful for carrier screening, but again, the amount of data that could be provided, okay, is tremendous. Okay, and it could be just pure raw genetic data. And when the provider wants to look whether to classify it as pathogenic or not, we have to know that the provider is accredited. Okay, because maybe if they use databases that are not updated, then what could have been pathogenic remain to be not pathogenic, okay, or likely. So there is a need. A responsible provider will have updated databases, and they will review the results at least every 3 years or so. Okay, it varies from provider to provider. So I mentioned this previously, predictive value may be low of that particular test, especially when there is no family history. False positive is a concern, especially when third-party interpretation services are used, okay? That's not directly involved in the consultation. And when you have results that are, you don't find anything, it could be reassuringly negative, right? Because you don't know to what aspect that they have sequenced, what variants they looked at. Okay, did they look at all the possible genes? We don't know. Okay, so we need to know the platform in which it was tested. Okay, and there's always that false perception of zero risk as opposed to population risk. I've never used the word zero risk in my genetic counseling sessions, right? There's always be that issue of population risk, okay? So there is thus a need to increase public awareness, and because it could actually trigger more tests, more surveillance, additional funding is then needed, okay? And there needs to be a regulatory framework, which actually it is not currently available here in Malaysia, right? But I'm confident in the near future where we hope so, okay? Now, the second last aspect of my talk is talking about how genetic counseling has evolved over the years, okay? So with the advent of high throughput technology, there is now integration of genomics into mainstream clinical care, right? So now genomic medicine is seen as being synonymous with medicine, right? So eventually, all healthcare practitioners will ultimately engage in genomic medicine. This is what it means by mainstreamed. It's no longer confined to just the clinical genetics clinic, but it goes beyond that, okay? So where these health practitioners will then, these are the non-genetic professionals, they could be specialists, maybe they could even be general practitioners, okay, or family practitioners. They are the ones who now then eventually have to communicate and manage results, especially when you have more and more direct to consumer testing, okay? So it has evolved from the traditional specialist genetic clinic to a specialist clinic. Maybe it's a surgical clinic, maybe it's a gynecology clinic, okay? So, but the key distinction remains in the fact that non-clinical genetics healthcare, they focus still largely on the individual, the patient that they are handling, but in the clinical genetics perspective, we look at the entire family, right? As of now, okay? It could be that in mainstreaming, they will be evolving even further, okay? So when we talk about the genetics clinic, we have to look at everything, especially and including the emotional context, which is the psychosocial aspect, Okay, so mainstreaming, we have to then talk about improving genomic literacy. Okay, we have to know that not all genes are deterministic, right? This is where having definitive results are important, but it's not possible all the time, okay? And we need to know, right, what tests are being ordered, okay? So sometimes you'll just order a particular BRCA gene, but actually maybe that family does not have a BRCA gene mutation. It could be other genes that are in place, right? But if that particular person only ordered genetic testing for BRCA1 and BRCA2 and then ultimately say, well, you don't have any risk of cancer, but there are a whole lot of other genes, right? That are responsible for familial cancers, okay? So you need to be mindful, what are the limitations of the test? Is it single gene? Is it multiple gene? And then what is the platform, okay? What is the technology that is being used? I think all of this must be addressed. Okay, so when we talk about mainstreaming, again, we talk about genetic counseling. That means we talk about the impact and the risk. And of course, a lot of pharmacogenomics is also practiced in clinical practice. But we have to remember these polymorphisms, these genetic variants, could be unique to a particular population. All right. So what might be common in the European ancestry may not even be found in Asian. So we need to know what's common within that particular population before we say, well, you don't have any, you're not a slow metabolizer and so on, no problems, you will not develop toxicity from taking this medication. Okay, you need to be very careful. Okay, so local data is actually very important. Okay, so online genomic information, there's always the need to upskill the force. Okay, so consent is important, and genetic counselors, genomic counselors we call them now, plays a pivotal guiding role. And what else? So we talked about mainstreaming in future. We know that there is a need to have genetic counseling practices set up in multidisciplinary or specialist clinics. I know in the hospital Tunku Aziza, right? They run Muffin syndrome clinic, neurofibromatosis, and so on, right? So they are very focused in the sense, but they bring in probably the specialists that are involved, okay? Or maybe you will also be doing counseling for specific charities, okay? And now in the era of COVID, well, thankfully, I hope we are recovering from that to a certain extent. We talk about telehealth. Okay, so I think we're going to have to embrace technology, like it or not. Okay, so which now moves on to telegenetics. Okay, so this is using a long distance clinical healthcare, right, for called telecommunication technologies to do the counseling. Okay, and in fact, in 2018, right, based on the use of telegenetics, there's been an increase in genetic referral just over a 2-year period. Right? In fact, it has almost tripled, right? So if access to tertiary referral center becomes a problem, I think telegenetics would be a way to go, certainly within the pandemic, okay? So there are issues about logistics that need to be addressed, cost, okay? But what's interesting is was there what was the patient satisfaction level like? So based on quite a lot of studies, right, they actually found that the patient satisfaction was comparable to when the actual patient went for in-person visits. And an example of this is maybe a woman who has to go for maybe she needs her spouse to be there with her, but because of logistics she couldn't, right? But with telegenetics, she has her spouse and her family to be there, right? Especially like if it was a poor perinatal prognosis, okay? And what about satisfaction in terms of the healthcare personnel side, okay? So this has also shown that there is a good acceptance level, and it is well received by the providers because it is an innovative way of providing consultation, flexible hours, and you can work from home, okay? Right? But there's always drawbacks that you need to be aware of, okay? There are legal and ethical issues, right? For example, I'll just highlight on this one, okay? What about reimbursement through insurance? Okay, maybe some insurance company do not think that telegenetics is the way to go, and they want an in-person visit. Maybe not quite yet here, but you have to be mindful. Okay, or maybe it cannot be for across the states. Okay, this is especially like in the US. Okay, and so these are some of the issues, especially legal and ethical, that we need to be aware of when we embark on telegenetics. Okay, and I just want to show this. What about the rare disease scenario in Malaysia? I think you see things started and picked up from 1997, but really I think although things have been steadily progressing, and this is by the Ministry of Health Malaysia. They developed a blueprint for genetic services in 2007, and genetic services at the KKM level was established in 2009. But I think you are also aware that the university hospitals, UKM, and USM, also provide clinical genetic services. Okay, and then in 2018 there was a rare disease budget, and I think things actually took off a lot further in 2019 with the establishment of a national framework of rare disease in Malaysia. Okay, so basically with that, they wanted to look at providing holistic rare disease management in Malaysia. So this was mooted by the Medical Development Division, namely Dr. Jafanita and her team, right? And this has been done already, basically. Okay, this has already been achieved. I'll just share here. So these are the committees that are involved, okay, for the National Rare Disease, okay. So there is a technical and clinical management support service. So these are this is headed by Dr. Ngu in HTA Kuala Lumpur, and there are individuals like Profiler and myself are also members of this, and we already have the Malaysian Orphan Drug Guidelines. Okay, this is other committee. And we also talk about health advocacy. This is very important, okay? So here we have the NGOs coming into place, patient support groups, like the Malaysian Rare Disease Society. Now we have a Genetic Alliance also in Malaysia, okay? And of course, ultimately, there's just so much to look at. We also have a technical committee on rare disease, which looks at the technology assessment. Okay, so I think we have moved on a lot more in recent years. Okay, and this has been already achieved. Okay, the definition of rare disease in Malaysia is a disease that affects fewer than 1 in 4,000 people in Malaysia. Okay, and it is a chronic debilitating disease which could be potentially fatal. And at the moment, there is a rare disease list here. And at present, there are 500 diseases that are listed in here. This is based on diseases that exist in Malaysia that are actively being managed. But this list will continue to be updated every now and then. Okay, so and this has already been released, the Malaysian Orphan Medicines Guideline. This is especially important, right, when you talk about enzyme replacement therapy. So these are some of the things that has already been done by the Ministry of Health. And the way forward now is we are now setting up a rare disease registry. Okay, and Ministry of Health is looking towards drawing up policies, right, related to management of a rare disease. Okay, so that's coming up. Okay, so I have another 6-7 slides to share, just to share some of the cases that I have seen with my team and colleagues in HCTM and also now HPKK. I just want to highlight some of the aspects that we faced. Okay, so in this first case, I actually saw 2 different families. They had children who were diagnosed with transfusion-dependent thalassemia. So they were referred for genetic counselling, and they wish to explore prenatal diagnosis. Okay, so for the first family, family A, right? This couple already has a daughter with homozygous beta thalassemia, and they have a son who is a thalassemia carrier. Whereas the other family, right, has a daughter, right, who's also transfusion dependent, okay, needed transfusion every 2 months or so. And here the parents were in their 40s. Okay, I think they married a little bit later in life. The mother was approaching 40 and the father was in his late 40s. Okay, so because it were the couples, the family was referred for genetic counselling, we have already attained a molecular diagnosis for this family. Right. So I talked about recurrence risk. Okay. Because in genetic counselling, we always talk about risk assessment, and especially for family B, because the parents were in their 40s, the risk of aneuploidies, right, your trisomies, for example, Down syndrome, Patau, and so on, was also raised. Okay, so sometimes, although you are referred for a particular condition, you have to see what are the risk factors are in play. Okay, so we then provided prenatal diagnosis options. Okay, and we also alluded to them. Well, of course, the couple will be looking towards having a non-affected pregnancy, but I did mention, what if you have a pregnancy that is affected? And these are days before all these other more sophisticated pre-implantation genetic diagnosis. Okay, so this was actually broached upon. I think this is important. You cannot just leave it to the end, or you don't want to even address this. Okay, maybe for religious issues, you just choose to not even address that. Okay, so giving them all the information, they made the informed choice that both families said if the pregnancy was affected, well, they would actually go for termination of pregnancy. Now, bearing in mind, these are families who are actually having children with thalassemia, so they understand what it's what happens to the child. Okay, so what happened then when they actually did a chorionic villi sampling? Okay, in a private center. Okay, so both pregnancies were affected. So the first family actually opted and did go ahead with termination of pregnancy. Okay, but the second family, upon discovering that the pregnancy was a male fetus, remember they had one daughter and they were in their late 40s, they actually, from wanting to do termination, they actually changed their mind to doing to continuing with the pregnancy. So these are informed choices. Sometimes things evolve, things happen. So these are social cultural issues and autonomy, right? So walaupun we give the information, the decision is the parents make it. Okay, so in this particular family B, they did have a boy and who is also now transfusion dependent. They both under the care of UKM, but they are doing well. Okay, so we have to look at the bigger picture too and the needs of the family. Okay, whereas for family A, although the mother did do termination of pregnancy for the affected pregnancy, she had another pregnancy in which it was non-affected. So she had a child who was genotypically normal. Okay. So that's the first case. Okay. Now the second case, this is the common referral that I get in my clinic. A child with a craniofacial dysmorphism, had hypotonia, growth retardation, learning disability, and the MRI brain showed cerebral atrophy. So amongst the genetic related investigations that were done included karyotyping, which was normal, fragile X, which was normal, and there was also an inborn error of metabolism screening, all normal. Okay. Now, what was interesting was that this particular family, actually, the mother here, right? This is taken from a paper that is published. Okay, she had actually two sons who had a similar phenotype. Okay, so these were the two that I saw in my clinic, right? And when I drew an extended family tree, okay, and this is part of genetic counselling, and my genetic counsellor, Puan Sharifah Azwin, always does a fantastic job helping me with doing this. Okay, so we discovered, okay, that there were several other family members that were affected, and as you can see here, they were only males, right? And it seemed to be passing through non-affected females. So this is classic of an X-linked recessive inheritance pattern. So this was at least more than 10, 12 years ago. We didn't have a diagnosis. We had a phenotype. We did basic investigations, yielded nothing, but we know the inheritance pattern. Okay, so what happened was, we gave them the recurrence risk based on the inheritance pattern, and the mother said, well, Dr. Zarina, I choose to not have any more children, okay, because I'm actually worried, okay, about the recurrence. But we revisited the diagnosis every few years or every year, because they come to the clinic anyway, every 6 months, every 1 year, okay. It's managed multidisciplinary, but when we reviewed the clinical phenotype, we found that it actually fit into a condition called alpha thalassemia mental retardation syndrome. So we actually sent blood from both of the siblings, and we got the diagnosis. Okay, so after we got the diagnosis, then we could test a few of the others, because here you will see that the mother, she was an obligate carrier, okay. She is an obligate carrier, sorry. And we actually tested her sisters. So the sisters here, actually, they were going to get married, but they decided to not have children until we get a definitive diagnosis. So this is where it's important to have a definitive diagnosis. Then you can provide uh, uh, cascade testing, and whether prenatal diagnosis is an option. Yeah. Okay, so this is the second case. And the third case is a patient who was referred, actually managed in the oncology, pediatric oncology unit, 2.5 years old boy, basically with precocious puberty, right? He already had facial acne, and his voice was already hoarse at 2.5 years, okay? And he had hypertension, okay? He had high blood pressure. And when we did imaging, right, we actually found that this boy had adrenocortical carcinoma. Okay, so what's next? Because this is adrenocortical carcinoma, this is a sentinel cancer for Lee-Fromeni syndrome. So this was drawn by Puan Azwin. Okay, so as you can see here, right, this is the patient here, the proband. But when we looked at the extended family, right, this is the father. So when we look at the paternal side, there was an aunt who passed away from breast cancer, right? There was an uncle who passed in his teenage years from osteosarcoma, and the paternal grandmother also unfortunately died from breast cancer. Okay, so we noticed, but that this is an autosomal dominant inheritance pattern, right? So what was done was basically, well, a lot of familial cancer syndromes have autosomal dominant inheritance, many but not all. So because adrenocortical carcinoma is a sentinel cancer for Lee-Fromeni syndrome, so we actually did a gene testing. Okay, so we looked at P53 and we sent this to UMMC, okay, and we found a missense mutation in the proband. We ultimately tested the father. Of course, we would assume that he did have it, but we tested him, and we actually subsequently offered the testing to others. So say like this woman here, she has unfortunately passed away. But there is always the worry about this, especially for them to have a risk, right? For having this particular mutation. So we actually could offer cascade testing to at-risk family members. So this is important when you have a definitive diagnosis, okay? So, and when you have that, then we can plan cancer surveillance better. Okay, for the individuals, like the father, right? We asked him to do regular surveillance, including colonoscopy. There is a particular guideline, right, for monitoring individuals who carry a mutation for Lee-Fromeni. Okay, so this is how genetic counseling, genetic testing has improved in how we manage the patients. Okay, now the fourth case, basically, I don't have the picture. I'm sorry. Oh sorry, I've already. Anyway, it's two siblings. Okay, this is there were actually three siblings in that family. They were of Pakistani descent, and the parents were first cousins. Okay, so when parents are first cousins, we know that they share 12.5% of the gene pool. So we are already concerned that this could be an autosomal recessive disease. Okay, so there was the elder sister, okay, and the younger brother who is a twin, okay, the other twin is normal, okay? They had similar craniofacial dysmorphisms, they had learning disability, and the elder sister, sorry, I'll just read out to you, basically had renal agenesis, okay? And she had a congenital heart disease, which was a ventricular septal defect, and she had dysfunctional uterine bleeding. And over the years, we noticed through our ophthalmological colleagues that the patient, both the siblings, had progressive retinal pigmentation. So at that point of time, this was easily over 10, 12, 15 years ago, right? We did the usual, although it seemed to be a gene level because it's autosomal recessive Mendelian. So we're probably talking about gene level rather than chromosomes. Nonetheless, a chromosome karyotype was done, which was normal, of course. And then a microarray was also done, which was also normal. But more recently, right, with the availability of collaboration overseas, whole exome sequencing was done. And this is the result. So after many years down the line, the diagnosis was clinched, and actually this sibling had retinitis pigmentosa, and this was a pathogenic mutation. So what we have learned from this is that although like in the first case where we had X-linked recessive, here we understand that it is likely an autosomal recessive disease. And unfortunately, there was that diagnostic odyssey that the patient went through, but now we have closure for the patient, right? So we have a definitive diagnosis based on the whole exome sequencing that was sent last year. Okay, I mean, these tests are expensive, okay, so not all patients can afford it, so we always try and look for other resources, but sometimes it's not so easy to come by. So for this particular family, had they want to test the other extended family members, it would then be possible. And I know that because certain ethnicities would actually have a lot more consanguineous marriage, but then this would make the family a bit more aware about possible consequences that may occur. And fifth case, sorry it's taking so long. So this is the second last case. So this is a family that basically has different types of cancers. Okay, the one in red is a colorectal cancer, and this was the patient that was referred to us, 42-year-old lady who has colorectal cancer, but not just colorectal cancer. There were others who had like lung cancer, prostate cancer, okay. There were several other cancers that were in play that came into this family history. So, you're probably wondering, so which of the familiar cancer genes should I be testing? Okay, so we did a gene panel testing, okay, and basically this was done in 2019, right? That they discovered this was for 47 genes, right? Because didn't seem to fit a particular familial cancer syndrome, so we extended to a gene panel testing. So there was a likely pathogenic variant identified, okay, in the MLH1. But what happened is, of course, we counsel based on that strong family history. We said that, well, close surveillance is necessary, etc., right? But actually, this is where it is very important that you have a good provider, okay, that will let you know. And this is 3 years later. They have recently disclosed to us that this is no longer likely pathogenic, it is now pathogenic, okay? So, and finally, the last case that I just want to highlight, this is a patient that was referred to me, probably, I think somebody is speaking. Somebody who's got craniofacial dysmorphism, myoclonic epilepsy, and learning disability. These are the common types of referrals that I get at my clinic. And this family, maybe the host can mute the person, or maybe the person can mute himself. This particular child had 2 other siblings who also had autism and learning disability. So when we sent the whole exome sequencing, there was no clinically significant variant that was detected to explain the phenotype. But this is where we found secondary findings. Remember the actionable genes that was reported. And this patient chose to know about the other genes that were being tested. So there was a likely pathogenic finding in this particular gene, okay, the rat gene. So we haven't called the patient back yet, but we're going to do so and explain this, okay? So basically, in summary, genetic counselling should be applied in both an ethically and culturally sensitive context, both at a multi-level perspective, remember, interpersonal, intrapersonal, institutional, and so on, okay? And the scope of practice for genetic counselling has evolved in the genomic era with the availability of direct-to-consumer genetic testing. Now we are using telegenetics and also mainstreaming genetics, okay? So there is a need to make sure that the services that we provide are indeed ethical and professional, and all who provide such services need to be accountable, be highly competent, and have integrity. And you must remember that we're not only handling the patient, but we are handling the other family members. And with mainstreaming, the role and good networking with other colleagues is important. And I think to reduce this issue about stigmatization and discrimination, right? I think we need to empower our society so that their knowledge and awareness improve. And of course, it's nice to know that in the Malaysian scenario, when it comes to the rare disease network, I think there are indeed very positive efforts from the Ministry of Health, okay, in consolidating the genetic services. And we can never work alone. So if we work together, multi-pronged, multidisciplinary approach, okay? So I'd like to thank you for your attention. This is the team, right? I'd like to acknowledge Dr. Jafanita from Bahagian Perkembangan Perubatan, who was involved in the rare disease framework, and of course my genetic counselor Puan Sharifah Azwin, right? And these are just some of members. This was when we set up our clinic in Hospital Chancellor Tuanku Mukris, and this is the team, right, in the Hospital Pakar Kanak-Kanak UKM. Okay, so I thank you for your attention. Okay.
Putus-putus, eh?
Oh, is it? I'm so sorry. I hope you heard most of the talk, and I'm so sorry for the gap just now. But I'll be happy to answer any burning questions. I think Prof Ali ada tolong jawab some questions juga ya tadi. Thank you so much for that.
Thank you very much, Prof. Zarina, for the very extensive and wonderful talk. Okay. Yeah. I think when there was some problem with your line, so there was a question tadi.
Oh, I think the
Yeah.
internet.
I think they wanted to know.
Yeah. I'm
Yeah,
sorry, even now
thank
the
you.
internet is a
Thank
little
you.
bit
Can you
choppy
hear me now?
on my side maybe. Yeah, I can hear but a little choppy, but boleh continue try?
Prof. Zarina, boleh dengar ke?
Yes,
Boleh
yes.
dengar saya?
Boleh. I can hear you.
Boleh dengar saya ke? Prof. Zarina?
Yes.
Dr. Malina boleh dengar saya ke?
I can hear you.
Saya boleh dengar, Prof?
Boleh.
Can you hear?
Ya. Kita orang
Boleh.
boleh dengar.
Boleh dengar saya ke?
Boleh,
Saya
Prof.
boleh.
Prof. Zarina?
Boleh,
Can you
Prof.
hear
I can
me?
hear you.
Everyone, can you hear me?
Yes.
Better.
Yes, Prof. Rasanya
Can you
better profile you can just stop your video kot. Mungkin maybe internet at your home tu. Okay, better.
Can you all hear me? Yes.
Yes, Prof. Yes, we can hear you.
Okay.
Yeah. Maybe
Sorry.
internet, line internet dekat Prof punya rumah kot, Prof Ali punya rumah.
Okay. Yeah, so Prof Ali, what is question just now? Oh, I can read here, is it? Where is it? in the chat. Is it in the
Yes,
chat?
there is 2 questions
I can-
already in the chat box, Prof Zarina.
I can pick it up first, Kot, whilst Profile
Ah, ah.
is. So, thank you. Okay. In order, what is the low-hanging fruit in order to improve the genetic counselling services in Malaysia? Okay. That's a tough question, to be honest, because I think, as you can see, there is already a framework for rare disease, okay? And because rare disease, 80% of rare disease have got a genetic basis, okay? So, basically, number one is we have to increase the number of people who can actually provide genetic counselling. Right, so this would be the genetic counselors, all right, and that's one, right? But to also have recognition for their posts. So we are basically trying our best to do this with the allied health side in the Ministry of Health. So I wouldn't say low hanging lah. It's been tortuous many years doing this. I think improve knowledge and awareness lah basically, right? So if we empower the people who work in the medical field, we empower the community, right? About the disease, about genetic testing. So people are a bit more aware. Then I think that's a positive move already lah. Yeah, but it cannot be low hanging in the sense that it takes a lot of effort from many personnel lah. Okay. So rest assured, I think there are things that are moving a bit faster sikit, we hope lah, of the last few years, we hope. Okay. The other question here, just wondering if the genetic counselling and screening as mostly done for pediatric patients only or including adult patients and cancer? Thank you for the question. Actually, when we talk about genetic counselling, as you can see, we handle both pediatrics and adults. So we do see adult patients even in our clinic, okay? And you can get a referral. Certainly, some of the referrals that I have had include cancer patients, right? About 10% or so, at least, of cancers are familial cancers, okay? So I think this is the one where, remember the family tree that I showed you that had a lot of family members that have cancer? Those are the types that we want to help pick up so that we can do testing, right? And then we can do early detection of cancer, right? And then some individuals, I think I didn't cite Angelina Jolie here, but some of them, then when they know that they have that particular mutation in the BRCA gene, then they do other preventive measures, like they do mastectomy, right? Angelina Jolie, upon discovering that she carried the BRCA mutation, she actually had mastectomy, okay? So yes, we do look at, we do get referrals for both pediatric and adult. Sometimes we get referrals from the specialists. Maybe is the oncologists themselves, or maybe it is the breast surgeon themselves. Okay, so sometimes some of them may be well informed in themselves that they can do the genetic counseling and genetic testing, but sometimes some of them also want to refer to us. Okay, so I hope that answers the question. Thank you. Can you share your experience how the parents at your center react to the genetic test results? Well, I think for some of the patients, as you can see, some of it is a diagnostic odyssey. Bertahun baru dapat diagnosis. Okay, but now with whole exome sequencing or microarray, we get the diagnosis even faster. Okay, so I think a lot of the time the parents want to know, right? So sometimes when they apply for a card OKU to get certain benefits, then or even people around them, they start asking, anak awak ada sakit apa sebenarnya? Then they feel there's no closure for them. Okay, and when you know a definitive diagnosis, it is important because then we can plan their surveillance. Sometimes, or maybe many of the times, the disease may not be cured, Okay, but then we can intervene and detect early. So I have to say, a lot of the parents, they they they, they, they embrace the, the results. Okay, because number one, we don't do the test immediately on the same day. Right? Test counseling talk about potential ambiguous results, about finding unexpected results. Okay, they think about it, and I'm sure a lot of them do research on the side. So many of the time, the parents memang embrace and terima keputusan tu ya. Disclosure, they want to move on, right? And they know how to better handle their children. And then they can also plan the future better. So, of course, along the way, there are parents who, depending on the condition of the child, can be quite challenging, right? And so we need to continually support not only the patient, but support the parents. Okay. So I do have patients who come and want to share. So sometimes my session takes a lot longer because they want to share their grievances. So I do what I can do, but if I feel that they need a bit more help from the psychological point of view, then I will refer to my clinical psychologist colleague. Okay. So apakah pandangan Prof Ali ada ke saya pula baca ni?
Ada.
I'm
No,
happy when Prof
no,
Ali
it's
comes
okay.
in whenever. Yeah. Those Eric
I'm
dulu.
here.
Apakah apa?
I'm here. It's okay. Carry on,
Okay, saya
Prof.
baca
Zarina. Carry on.
Okay,
It's okay.
sorry
Carry
Prof
on.
Ali, I wasn't sure. I baca saja
Carry
dalam
on.
chat.
Carry on. Carry on.
Okay. Okay. Apakah pandangan Prof berkenaan harga ujian genetik yang agak tinggi? Dan bagaimana ujian genetik dapat diluaskan lagi bagi pesakit yang memerlukan? Yeah, this is okay. Dulu these genetic tests were not even available on the shores of Malaysia, but now we have a lot of genetic tests that are now available in Malaysia, either in apa tu HKL, either in IMR or the university hospitals or in private laboratories. Yeah, so yang semua yang macam microarray or whole exome sequencing, it could be a sample could be sent to the local labs, but it could be sent also through the local labs and sent outside ultimately. Okay, because these tests are expensive. Okay, like a whole exome, if we do one test, one patient, it could cost about 3,000 ringgit, 3,000 ringgit. So so that's expensive. Okay, so but the cost has actually come down over the years. So, for example, macam the gene panel testing that I sent, okay, I'm not here to promote any particular company, but there are companies that actually offer gene panel testing for as low as 1,000 ringgit. 1,000 ringgit is still a lot of money, but it's much reduced from the days when I first started my clinic. It used to be 6,000, 7,000, 8,000, yeah, but now it is 1,000, and they can test many genes. Okay, so it has dropped down. Okay, that's a positive point. Walaupun 1,000 remains to be a lot. So I think this is where we hope that either the centers that are managing the patients, sama ada dekat Kementerian Kesihatan atau the university hospital, we actually seek help through our Jabatan Kebajikan Pesakit, Social Welfare Department, because sometimes they will have the resources, kita boleh rujuk lah, sometimes ada duit daripada apa tu Baitul Mal atau from other NGOs. Okay, so we refer, right? Or sometimes it could be maybe majikan ke, although it's quite difficult lah, ya. So we try our best to support, and then kalau tak dapat duit money from them, sometimes we do this collaborative network lah with some of these companies, right? So for some of the more recent patients, right, we work closely with some of the providers overseas who actually give compassionate free testing. Okay, so with the hope that ultimately we will offer and send patients at the cost lah, ya. So maybe this does not answer directly lah, ya, soalan Cik Abdul Rahman tu, ya. Kita cuba dapat bantuan lah keuangan di mana mana kita boleh dapat, kita cuba dapat free kalau kita boleh dapat, ya, atau kalau tak, then we we make a clinical diagnosis lah and we take it from there. Okay, nak luaskan lagi ni maksudnya increase awareness lah. Okay, basically that testing now is actually readily available. Sekarang ni kita boleh tak semestinya hantar darah ya ke luar negara pun ya. Kita boleh hantar buccal smear, saliva sample semua tu, ambil sampel, okay, kikis gagal semua dalam, okay, and we can send that sample. Okay, so no longer need to, because bila kita hantar blood, it is a bit more difficult. Okay, so thank you, Prof. I have one question. In terms of genetic tests ordered by your clinic, may I know where were the tests performed? Is it mostly UKM, outsourced, and is it affordable? I think I answered part of it, yeah, Hidayati just now. Some tests, certainly things like karyotyping, and maybe like for thalassemia, right? It is not a rare disease, but it's a genetic disease. We can do that in UKM, all right? We have the ability to test certain in UKM itself, dalam Hospital Chancellor Tuanku Mukris lah, ya. Kalau tidak di UKM, then certainly dekat IMR, ya, di Kuala Lumpur, Institute of Medical Research, atau dekat Hospital Kuala Lumpur, ya. Mereka ada jabatan genetik, ya, that has both cytogenetics and molecular genetics. So I send it to there. Or ultimately, of course, I send to private labs who will then maybe send it overseas, or I send it direct overseas. So I've used a few companies. I suppose I can just mention, I've used Invite, for example. I've used 3 billion, okay, for whole exome sequencing, and a few others. I've already mentioned about the cost lah. Yeah, it is a bit challenging, but we try our best to get the support where we can, or we try and negotiate. Sometimes some of these other labs are based in university labs overseas. Sometimes they are doing research. So sometimes we send our samples to be diagnosed there. Okay. So if it's not at the private lab, we also collaborate lah for research for the purpose of getting a diagnosis. Okay. So I rasa itu saja kot yang saya dalam. Yeah. Okay.
Yeah, thank you very much, Prof. Zarina,
Yeah.
for the excellent talk, and also I think for providing the answers to the questions tadi. I think ramai yang nak tahu lah pasal genetic counselling ni, because it's a new field, especially in Malaysia. And I think people wants to learn more lah about genetic counselling, and also to be involved, also to get knowledge lah, to have more information and knowledge about genetic counselling. Tadi ada discussion pasal pasal training program lah that you have started dekat PPUKM.
Yeah.
And there were questions about the qualification. There was a question on qualification lah. Is it just for medical doctors? So I've given the answer, bukan. So it's open for anybody with a degree, with a basic degree in science, science atau related medical field, betul Prof. Zarina?
That's right. Betul.
Yeah.
So in fact, you're right, Prof. Alea. So most of my, we started the program in UKM in 2015. Our first intake. So in fact, I will have to say that all our graduates so far, they have a science degree. So either they have a biomedical degree, a genetics degree, a psychology degree. Yeah, so it is medical related or health related lah. Yeah.
Yes, apa ni, boleh ke kalau macam say a lecturer, a lecturer, medical lecturer ataupun even a lecturer with a PhD, they are interested, they are doing work in genetics, not in genetic counselling, tapi in genetics, research in genetics, for example, a pathologist. So she's lecturing and doing research in say hematology, and then doing a lot of molecular work related dengan genetics pun, patient thalassemia, for example. And then dia interested to do genetic counselling, this 2-year course, ataupun a shorter course, shorter training program. Is that possible ke, Prof. Zarina? Shorter, maybe 6 months ke, yeah, less than 1 year lah, as a sabbatical, maybe 9 months ke. Is that possible ke, Prof. Zarina?
So kalau this person wants to do a full 2 year, the MSc is a full 2 years program, memang boleh full 2 years. Absolutely, betul, the criteria is there. Tapi we don't have any micro credential system set up for this program yet. Kan, because I think that would be the way to go. I've had a few requests for this too, right? Because I think, but at the moment, I think we don't have a professional accreditation body for genetic counselors. But I think we are looking for those who have undergone a full 2 years program to be called and certified as genetic counselors ultimately in Malaysia. Right? So kalau this one, then that the issue lah, maybe dia tak complete the training walaupun dia ada some medical background, ya. So there is no platform yet to offer micro credentialing, what we call stack-on degree, where you probably don't have the time to do the full 2 years, but you take a bit of this, you know, at your pace, that kind. We hope to do that in the near future. So tak ada. So we can't offer a master's for 6 months. We probably could say at the best attended part of the course lah. But not as a degree that is apa tu, recognized by MQA lah.
Okay, Prof. Zarina, because maybe dia setengah lecturer, dia berminat in genetic counselling, tapi dia maybe just nak buat just during her sabbatical, 6 months ke, 8 months ke. So probably I think that there would be people looking for this opportunity lah. They can be surgeons, they can be people like physicians, ONG specialists. They just want to know a bit about genetic counselling, 3 months, 6 months, during sabbatical. So
I think you're right. Because now, especially with mainstreaming that I mentioned just now,
yes,
and we have, I think, Puan Suk Yi, she's a certified genetic counsellor who works with Cancer Research Malaysia, right? She published that paper about mainstreaming in Malaysia, right? Talking about management of BRCA, talking about mainly the ovarian cancers. Those who have undergone mainstreaming, the satisfaction level is good. So I think this is doable, like what you mentioned, kan? If we want to do this and empower other specialists to do this, right? Then a structured course would be the way to go. But I just want to mention, apart from the doctors, the nurses also, right? Some of them also want to do this 6 months to a year, just to do that foundation in ni. But that's the end of the day. Dia macam tu lah. Kalau you want to ultimately be called a certified genetic counsellor, I think we are looking towards 2 years. And somebody just now asked, memang full time saja. We don't have part time at the moment. Okay, so kalau your job scope is as a certified genetic counsellor, we expect the full 2 years. Okay, tapi if you are talking about some of these other aspects, maybe kena think a bit out of the box lah. Yeah, something to do, and you're absolutely right lah. That's the way to go forward.
Thank you, Prof. Zarina. I think interest of time, we have really exceeded. It's supposed to be just about 1 hour. Now I think it's
I'm
almost
so
2
sorry.
hours.
I'm guilty for that also.
No, it's okay. I think everybody enjoyed that. There's a lot of questions. People want to know more. I'm very sure that this is an interesting field, and memang ramai orang nak tahu lah pasal this new area lah. So thank you again, Prof. Zarina, from us, from everyone. I think I'm sure the participants have enjoyed your talk tremendously. We thank you again. And also from Pusat Genome, the organizing committee, we thank you, for sharing with us your knowledge, before I leave, I don't know, I can hand over back to Dr. Amalina or Dr. Zarina. Would you like, to say something before, we close out the webinar?
Okay, thank you, Prof. Halil. Thank you so much to Wait, actually, I'm in the middle of one more meeting, the Majlis meeting. So we just endorsed the exam results. So thank you so much, Prof. Zarina, for giving this wonderful talk. I think yes, because I think it's very important and a good information for our students, lah, especially for our MPAS students, and also maybe a few of them actually from the MMed pediatric punya program. So it's very good. So thanks again to Prof. Zarina. Okay, so hopefully that this will benefit to all the staff as well, for our students especially. Okay, thank you so much.
Thank you.
Okay,
Thank you.
thank
Sorry
you.
for the glitch. My
No, it's
pleasure
okay.
always.
It's okay. It's already. It's always happened actually for the outsiders actually from outside of USM. Yeah, if you are using the WebEx. Okay.
Okay.
Any
Thank you
more?
so much.
Okay. Any more? Amalina, Dr. Amalina, do you want to say something and anything else?
Okay, thank you very much, Prof. Zarina, for the very insightful talk just now. And you have answered every single question in the chat box. And we really appreciate your talks today and your sharing, your very insightful sharing today, Prof. Thank you very much.
Participant put almost more than 55, 58, I think, just now. 58 participants, yeah.
Alhamdulillah.
Very good.
Okay.
Okay.
Thank you.
Thank you.
My pleasure
you,
always.
semua.
Alright.
Okay.
Thank
Okay,
you,
have a
everyone.
nice day.
Thanks.
Thank you very
Okay.
much.
Bye-bye.
Bye.
Assalamualaikum.
Salam.
Waalaikumsalam, Prof.
Eh,
Birthday nak buat apa tu? Boleh tak, Wan?